So, good afternoon, everybody. Thank you so much for the kind introduction. I appreciate I'm the first after you've all eaten, so I hope there's no postprandial slump, you don't fall asleep while I'm presenting. And please bear with me while I show you some nice examples of MR utilising Canon's AI algorithms from our Neuroradiology department in Paris. Here are my disclosures. Sequences and options used in this lecture are clinical products unless stated otherwise, and you'll see this work in progress sign. A little bit about myself and where I work. So as Dr. Paul said, I'm Irish. I did all my training in Ireland and then moved to Paris for my fellowship. And it was really a dream to work in Rothschild Foundation Hospital. I joined staff in 2019 and for my sins was subsequently appointed Deputy Department Head. And I do general neuroradiology and my particular niche is neuro-ophthalmology. At Rothschild, while the site isn't that big, we have quite the output with about 50,000 exams per year spread over our 4 MRs and our CT. We're a stroke centre with separate neurodiagnostic and neurointerventional departments. And we're also a tertiary referral centre for MS, neuro-ophthalmology, ENT and neurosurgery. So on site we have a Vantage Gallon 3 Tesla magnet and a Vantage Orion 1.5 Tesla magnet, and all of the images in this lecture were acquired at our hospital on either system. So when it comes to AI, speaking in broad terms, the possibilities are endless, and the conversation is often dizzying, which is why I want to begin by providing some framework. And thankfully, the Canadian Association of Radiologists Artificial Intelligence Working Group provided just that with their white paper in 2018, in which they provided this diagram, which decomposes our day or our role into individual tasks, each task being a potential opportunity for AI, not so much to intervene, but to aid us in our daily clinical practice. Today, I am focusing specifically on image acquisition and the image quality stage of the timeline, complementary to the groundwork that Valentin has already laid in his talk just before lunch. So to talk about image quality, and like most things in life, unfortunately, you can't have it all, which brings me to the infamous triangle of compromise. So objective ways to assess image quality, as we've heard, are signal to noise ratio and contrast to noise ratio. Signal to noise ratio then is influenced primarily by voxel size, field of view, matrix size, as well as size thickness, and then contrast, meanwhile, is the ability to differentiate signal abnormalities from surrounding structures. Having said that, there's no consensus as to what the optimal parameters are. Tastes often differ, and you just need to ask the neurosurgeons in our hospital for their opinion. In this example, the larger voxel size means that the scan time is short, but our signal to noise ratio isn't great. And if we want to increase our SNR, then we need to decrease our voxel size, but the caveat is that our scan time becomes much longer, which is where artificial intelligence comes in to provide a solution to this current challenge. And Canon have developed multiple sequences integrating AI and deep learning reconstruction, allowing us to increase SNR and CNR for constant scan time and spatial resolution. So earlier, Valentin explained the technicalities behind ACE, which is a denoising DLR application that improves image clarity and allows you to choose the denoising strength. And then the next step is PEAK, in image quality improvement, using DLR algorithms to denoise and reconstruct images with high matrix size. Validation studies of denoising DLR algorithms are clearly needed to evaluate their effect on pathological lesion detection. And in this paper published by Professor Tourias's team in Bordeaux in AGNR in 2022, they performed 3D flare sequences with decreasing scan times, but identical spatial resolution, which obviously resulted in more noise. And they showed that ACE improves subjective and quantitative image quality, with the fast sequence reconstructed with ACE being equivalent to the standard optimized flare, slicing half the time, scan time off of the sequence. These examples then are of peak from the literature. So the first from Advanced Neuroimaging in late 2023, and they analysed 33 time-of-flight MRAs with and without peak, and both SNR and CNR were higher with peak. The second study then from Matsuo evaluating diffusion-weighted sequences showed that peak increased SNR and CNR with no loss of quantitative properties of the ADC. Excuse me. So for the purposes of this talk, I'm going to show you examples of the effect of ACE and peak on conventional sequences and non-morphological and advanced sequences. To do so, I'm going to illustrate it mainly on multiple sclerosis, which we all know is the leading cause of disability in young adults and something that all radiologists have encountered at some point in our careers, and a disease in which lesion detectability is crucial. I don't know of any department that isn't under pressure to scan more and more patients all of the time, and we need solutions to maintain image quality and enhance our diagnostic accuracy, but without the time penalty. MS is fitting to discuss because hot off the press from ECTRIMS in Copenhagen last month are the revised McDonald criteria. So there's lots of changes afoot. A diagnosis of MS is no longer strictly a clinical one and can be made on MR, and the optic nerve has also finally been included as a lesion location. So the pressure now is on for us to be as precise as possible in describing lesion location, and also we need help in terms of the our diagnostic accuracy to not falsely label patients with multiple sclerosis for lesions that don't respect the true definition of the locations. So now our first case of an MS patient to see the effect of noise reduction thanks to ACE. This is a right posterior medullary lesion with a conventional filter on the left and ACE on the right with improved lesion contour detection. Sorry, oops, and excuse me. Sorry, I must go back. Sorry, there's a time lag between me pressing and it coming on, so my apologies. That's okay, I'll just continue on. This series of images in the sagittal plane are the follow-up of an MS patient over the course of 3 years. The first two images from on another system, and the two on the right then with the conventional filter and ACE from our 3T Vantage Gallon magnet. So we can see that the lesion in the posterior pons in the region of the medial longitudinal fasciculus is much more clearly visible after ACE, and finally explained an internuclear ophthalmoplegia that had gone unexplained radiologically up until then. Obviously, in retrospect, it was there, just too noisy for it to ever have been called confidently. And there's also then an additional lesion in the upper spinal cord, which had up until then been missed. This is the same patient, just to show you in the coronal plane, the T2 high signal in the intracanalicular portion of her left optic nerve, consistent with a previous episode of optic neuritis. And we can see that with ACE, there's a vast reduction in noise compared to the conventional filter and the scans that were done on another system. So, if I was to have asked for a show of hands to say which scan do you think was done on 1.5 or on 3T for the image on the left, do people think it's 3T, 1.5? No. So, pardon me? 1.5 is what people are saying. So actually, in fact, the image on the left is 3T and the one on the right is 1.5 thanks to ACE. So we can see that the benefit of ACE is that we can achieve a level of signal to noise ratio and contrast to noise ratio on our 1.5 system that was previously only reserved for 3T. And this is the same patient again, just to show you in the sagittal plane, and that there's no loss of diagnostic information having added ACE. Moving away from MS temporarily, just to show you this beautiful case from a few weeks ago of a patient who presented to our emergency department with abrupt onset diplopia. And the high resolution diffusion weighted sequence shows an acute ischemic infarct in the region of the right third nucleus. And the detail we achieve after ACE, I think, is incomparable. The signal to noise is markedly increased. And the infarct was due to a tight stenosis of the basilar trunk. From an atheromatous plaque, which you can see is this area of non-circumferential enhancement on this 3D black blood vessel wall sequence. Remember then our original MS patient with this right posterior medullary lesion on our 2D T2 weighted sequence. Well, now you get the benefit, not just with ACE, but with PEAK compared to the conventional filter, with sharper lesion borders compared to the normal appearing parenchyma. Zooming in on these T2 weighted sequences, you can really appreciate the exquisite detail you get from PEAK with these of the virtual Robin spaces. And in the region of the orbits, optic nerve and hippocampi on this series of images, which illustrates so nicely the different grades of image quality from decreasing noise from left to right. PEAK can also be used to reduce scan time, again changing themes slightly, but this is a lovely case of a left anterior clinoid process meningioma. PEAK in this setting allows us to knock nearly half the scan time off without any loss of diagnostic information. Next up then is spinal cord imaging, which is not necessarily everyone's favourite. Conventional MR techniques have their limitations. The spinal cord is a thin structure, it requires a large field of view, scan times are long, prone to motion artifacts, and sequences require higher resolution, higher SNR, and motion robustness. More advanced sequences are needed to address the complexities of conditions like MS. And this T2 weighted sequence of the cervicospinal cord of a patient with MS, we can already see that the STIR sequence adds better contrast than T2. And when compared to ACE reconstruction method, PEAK reconstruction renders the lesion edges even sharper. And a clear definition of the lesion edge is important as it allows us to identify progressive, slowly expanding lesions, which could potentially incur treatment change for the patient. In certain cases, conventional sequences including STIR may not detect all lesions in the spinal cord and bring in the MP2 RAGE sequence, which has been a game changer in all of our clinical practice, certainly mine, to the extent I often ask myself how I survived without it. It's a 3D sequence that offers superior contrast and reduced motion artifacts. It uses 2 flip angles, 2 inversion times, and the sequence allows us to reconstruct both the real image and the T1 relaxation map, and we can also apply DLR applications to it. In this example, the T2 weighted sequence provides detailed anatomical information, but the tissue contrast is limited. Intensity is proved with the T2 STIR sequence, as indicated by the top arrow, and then with the MP2 RAGE sequence, we detect lesions that weren't visible with conventional sequences, as shown by the bottom arrows, and the addition of PEAK technology sharpens the lesions even further and increases their conspicuity. The real benefit of PEAK reconstruction on the MP2 RAGE sequence in the axial plane is that in the axial plane actually is when we put it into MPR, and you can see that there's improved signal to noise and increased sharpness of the lesion edges. Now to move on to another conventional sequence of Canons to which DLR can be applied, and that's iterative motion correction. Iterative motion correction does exactly what it says it does. It's an iterative image correction technique for 2D sequences that aims to reduce motion artifacts caused by sporadic movements. Because in the real world, patients are going to move, cough, snore, blink, etc. And combined with ACE, IMC acquisitions can significantly elevate image quality. It works in real time, providing the motion-free image, and then the image with the movement artifacts can be secondarily reconstructed. This is a great case to show the benefit of IMC. So the standard of care in our hospital for thrombolysis calls is MR. This is a patient who, this is his follow-up at 24 hours with his huge acute left MCA territory infarct. And he was post-thrombolysis and post-thrombectomy with hemorrhagic transformation graded Heidelberg 2. And you can see on this 3D weighted, flare sequence, the patient was obviously very agitated and moving an awful lot. So we abandoned ship. And we performed then this axial flare sequence with IMC. This first image then is the IMC with the motion artifacts that was secondarily reconstructed, just to give you the benefit of what it actually has done. So you can see here that these are all of the movements. And the next image here then is with IMC turned on. So you can see that all of the movement artifacts are completely gone and the diagnostic information has been preserved. So, I mean, that's all well and good, but why exactly is that so important? We need to be able to reliably calculate the volume of this infarct, as this has major repercussions for the patient. And if the infarct is over 145 cc's, the neurosurgeon then has to bring the patient to the OR for decompressive hemicraniectomy as a preventative measure for the impending edema. And that's exactly what happened to this patient. This is his post-op CT showing no further midline shift. Leaving conventional sequences behind us, let's move on to the application of ACE and PEEK on non-morphological sequences and advanced sequences, all works in progress. This scan then of a patient who had a treated dural AV fistula, had recent onset of left-sided paresthesia, and conventional morphological sequences were deemed normal. Looking at the arterial spin labeling sequence superimposed on the flare sequence, we can see an area of hyperperfusion in the left posterior temporal lobe and the bilateral posterior thalami in the region of the pulvinar nuclei, consistent with seizure activity. And I provided both ACE and PEEK reconstructions here, which better delineate the abnormalities so that they more closely correspond to the anatomical morphological sequence underneath. Another interesting sequence then that has been released by Canon Medical Systems is the inhomogeneous magnetization transfer. This is a quantitative technique specific to myelin, and from this sequence a ratio map can be calculated and employed to investigate demyelination in MS patients. The modified version of magnetization transfer takes advantage of the long dipolar relaxation time values associated with myelinated structures to selectively isolate the contribution of myelin. So visually, what does that give? So in this example, these MS lesions are visible as a signal decrease in dark blue on the overlaid IHMT ratio map, reflecting a loss in myelin content compared to normal appearing adjacent tissue. And the demyelinated lesions are more clearly visible when ACE is applied. Another MS patient with an IHMT ratio map overlay, and with ACE, the lesion contours again more closely resemble the morphological flare sequence that we have put underneath. IHMT can also be performed for the spinal cord. The sequence with a classic filter covers the cervical spinal cord in 3 minutes with an in-plane resolution of 1.9 by 1.9 millimeters. And this example was acquired with the 32-channel head coil, but can also be done with the 16-channel coil combined with the body coil. The overlaid IHMT ratio map, the lesion is visible as signal decrease in dark blue, which you now know reflects a loss in myelin content compared to normal appearing adjacent tissue. And by integrating ACE into this IHMT ratio sequence, we can improve the visualization of the demyelinated area. Multiple research groups demonstrated the higher sensitivity and specificity of IHMT to myelin content in MS patients compared to conventional magnetization transfer in the spinal cord. And lastly, 3D callus is an advanced sequence. It's a multiparametric imaging technique that can provide at least 10 different contrasts, either anatomical like T1 and T2, or quantitative such as myelin map and T1 maps. So in other words, in 4 minutes, we can generate up to 10 synthetic sequences for the price of 1. We can also apply ACE and PEEK technologies to enhance these synthetic sequences. So for continuity's sake, again, I have an MS patient with his left frontal paraventricular lesion indicated with the yellow arrow. And along the top, you have the native sequences, which are individually acquired. And along the bottom, using synthetic MR software, we generated synthetic flared T1 and T2 weighted sequences with the same lesion remains visible. Callus then is not limited to the brain, as we can see this lesion at the level of C2 on the synthetic T2 weighted sequence generated using synthetic MR. So I would like to extend my sincere thanks to my esteemed colleague, Dr. Julien Softovsky, and to our clinical engineer, Emilie Poyon, for the generosity in sharing their clinical cases for the preparation of this talk. And lastly, thank you to Canon for the opportunity to speak in the hallowed halls of the TIFF.